Thanks, Dr. Liu. Good morning, everyone. My name is Elena Miller. I'm a PGY5 Geriatric Fellow at the University of Toronto. And today I'm going to be talking to you about a journal article called Geriatric Co-Management for Cardiology Patients in the Hospital, a Quasi-experimental study. This article was published in JAGS this summer. I have no conflicts of interest to disclose. Today, I'm going to review the study to critically appraise the study's methods and results, and to discuss the implications for clinical practice. Some background. Heart disease guidelines often do not consider the complex needs of frail older adults. And up to 60% of patients with heart disease suffer from one or more geriatric syndromes. And patients with cardiovascular disease and a geriatric syndrome are 4 times more likely to be readmitted and 2 times more likely to die. We know that geriatric co-management in hip fracture reduces functional decline, complications, length of stay, and mortality rate. And it was based on this that this study was started, and the objective is to determine whether a nurse-led geriatric co-management program for patients in the coronary care unit leads to better functional status at hospital discharge. The study overview. The patient population was patients over age 65 admitted to the cardiac care unit at University Hospital in Leuven, Belgium. The intervention group had co-management with a geriatric nurse, geriatrician, occupational therapist, and this team initiated discharge planning. They started physical rehab within 48 hours of admission, promoted and trained ADLs, and prevented geriatric syndromes. The control group was usual care. And in this case, they were cared for by the cardiology multidisciplinary team, and a geriatric consult could be requested. The primary outcome was functional decline at discharge, measured by the CATS index. The secondary outcomes were during the hospitalization, delirium incidents, symptomatic nosocomial infections, obstipation, and falls. At discharge and 6-month follow-up, they looked at the following outcomes: physical performance, grip strength, cognitive status, length of stay, quality of life, self-perceived health, and falls. This is a quasi-experimental before and after study. Patients were recruited within 72 hours of admission. The inclusion criteria was patients admitted with acute cardiovascular disease or for TAVI. The length of stay was greater than 3 days, and they required a high risk of functional decline or complications. And I'll talk more about this in a moment, but it was patients were risk stratified. The exclusion criteria was being admitted from another hospital, receiving palliative care, or being low risk for functional decline. Over 1,976 patients were assessed for eligibility, and from those, 454 were included in the study. And this is where the quasi-experimental part comes in, where from September 2016 to June 2017, patients were allocated into the control group, and 227 patients were in the control. And then of those, they were risk stratified by the geriatric nurse. And this was an assessment that evaluated 12 domains to determine whether a patient was either high risk of functional decline or at risk of acute complications. If so, then they were followed up at his hospital discharge. And at that point, there were 152 patients, and then followed up again in 6 months. And there were 121 patients. 30 patients died. The intervention group, however, the data was collected from January to December 2018. And of those, 151 of those patients were either at high risk of functional decline or at risk of acute complications. 147 of those patients were assessed at hospital discharge, and then 115 were followed up 6 months post-discharge. 26 of the intervention group patients died. The baseline characteristics, the control group had a better mini-cog score, but had worse anxiety and a higher cumulative illness rating scale compared to the intervention group. And those who were in the intervention group, 88% were offered co-management, 80% received a CGA and care plan, 60% of those with functional decline received ADL training, and 40% completed the self-exercise program. The in-hospital outcomes in the geriatric co-management group showed less functional decline. They had a CATS ADL score of 8.9 versus 9.5 in the control group. And this was statistically significant, but did not achieve the minimal importance difference of 1 point on the CATS ADL. In terms of secondary outcomes, there was statistically significant lower incidence of delirium, less obstipation, and less nosocomial infection. At 6-month follow-up, the geriatric co-management group had statistically significant better functional status, higher quality of life, and fewer fallers. Again, the functional status did not achieve the minimal importance. They did moderator and mediation analysis and found that those at highest risk of functional decline and those who performed their self-exercises showed the greatest difference in CATS ADL score. So the critical appraisal, are the results of this trial valid? Well, the study lacks true randomization inherently due to the quasi-experimental design. However, this design is commonly used to study models of care. Were the groups similar at the start of the trial? Almost. They, especially given the non-randomization, they did have differences in cognitive status, anxiety, and comorbidities. Aside from the allocated treatments, were groups treated equally? No, and I say this because the control group could access geriatric consults. So this could blunt the effect of the intervention group, since in effect, both the control and the intervention were receiving similar treatments by the geriatric team. And did the patients in the intervention group have co-management? No, the fidelity of the intervention was lower than I think would be expected. Only 80% got a CGA, 60% ADL teaching, and only 40% of the patients performed the self-exercises. In terms of external validity, are the study conditions found in real world? Yes, especially the way the group did the stratification to identify patients who benefit most from intervention. We do this commonly in geriatrics, where we try to identify the patients who would benefit most from our services. So for example, in hip fracture, it's age over 65 and hip fracture. Are the results generalizable? Not yet. I think further randomized control trials are required because this was a single center study with highly experienced nurses and geriatricians. And a major advantage of this model is it's nurse-led. So it can serve geriatric resources as geriatricians are in short supply. So I think this model shows potential. The bottom line is that geriatric co-management in the CCU was effective at improving functional status at discharge, but did not achieve a minimal importance. And the program improved secondary outcomes of delirium, infections, obstipation, quality of life, and falls. But before we use this model in our CCUs, more evidence is required. Thank you.
Thank you so much, Elena. Very nice and clear presentation. We have time for questions and discussion. Let me just change my view so I can see everybody. Anybody want to unmute and ask a question or make a comment? Maybe I can just ask for clarification. Was the geriatrician only involved if the person developed complications or if they were identified as high risk?
They were involved in both. The geriatric nurse would do the daily rounds with the patient, and then the geriatrician would review at the end of the day in a multidisciplinary way.
Okay. And Shabir had a question?
Yeah, thanks, Elena. Very nice presentation. You mentioned that you think the next step is a randomized controlled trial, and I want to open that up for discussion and get thoughts from you and maybe other people listening that on the one hand, I agree with you, it's not randomized, there are biases, and randomization will eliminate some of those biases. On the other hand, if this is a model of care type study, and we know that randomized trials don't answer every question and are not always feasible, why do we need another randomized trial? Can we not get evidence from other study designs that may be easier for the patients, cheaper to do, and likely to give us the information that we need, particularly since what they're studying, this isn't completely novel, to be honest. Like the idea of geriatric co-management has been studied in so many settings. So why do we need a randomized trial? And are we setting ourselves up for demanding a level of evidence that is just not going to be achieved?
Thank you so much for that question, Dr. Alibi. You do raise some very good points. I do think that we need further study in this area. And the reason is that this is a single center with very experienced geriatricians and the nurse practitioner. And I wonder whether we would get the results that would warrant our geriatric services. So, you know, we are in short supply and we want our efforts to glean the best outcomes possible. So I think to be able to achieve that, we need more studies.
Gary, did you have a comment?
Yeah, I'm just gonna follow up to Shabir's comment. There's a bit more sophisticated approaches to before-after design studies that, of course, continue to have imperfections, but are a lot better than single center before-after. And one approach to that is having multiple centers do before-after during the same periods of time. You can have several centers introducing the intervention and several that do not. One of the important aspects of that is controlling for sectoral trends and changes that can occur because healthcare changes so quickly. It's nice to have a group of sites that have not introduced the intervention with before-after data and making sure that you don't see changes that may be similar to sites that introduce the intervention for various reasons. The questions I have is, or maybe it's a comment, it would be nice in the characteristic table to see frailty, a measure of frailty in the groups, because it's not clear to me, since the comorbidities were different, these groups may have been quite different from each other, and that would be a real challenge to the results. The other thing that needs to be considered in studies like this, where there's longer term follow-up, is did both groups have equal follow-up? That's important because the group that had co-management, it's possible that they may have had follow-up geriatrician or geriatric nurse practitioner follow-ups, whereas the control or the pre-group may not have had such follow-up. So there could have been differences in the follow-up that may have impacted the results that would be critically important to be aware of.
Thanks, Gary. Carol Cohen put in the chat a question about how many of what percentage of the control group had the geriatric consult?
I did not see that information. They just made it clear that it was available to them and that some consults occurred.
Thank you. And a nice comment from Christina about the language requirements.
Speaking of before and after study care models, I'll be presenting on kind of a similar theme to Elena. So my name is Ramiz. I'm a fourth-year geriatric medicine fellow. And the study that I've chosen to highlight for Journal Club is a Canadian study titled Clinical Effectiveness of the Elder-Friendly Approaches to Surgical Environment Initiative in Emergency General Surgery. It is a mouthful to say, so I'll call it the E-study for short. I have no conflicts of interest. Just brief objectives for today. So we'll talk briefly about surgery in the older adult population, and then we'll move into ACE philosophy and its application in the surgical patients, which I think is important for us to understand if we're going to appreciate what the EASE model tried to do. Finally, we'll review the journal article and end with critical appraisal. So a few comments on older adults and healthcare demands. I think it's no surprise to most of you here that the population of Canada is aging, and by 2040, about a quarter of the Canadian population will be over the age of 65. And if you look at data from Canada from 2011 and from US from 2015, we know about a quarter to 1/3 of all patients receiving surgical interventions fall in that older adult patient population group. And so if you take those two comments together, it's not hard to imagine that as Canada's population ages, so will the demographics on surgical wards with more older patients getting surgical interventions. And we know that the older adult population is different from the younger adult population by virtue of comorbidities and frailty, in that they are at a higher risk of postoperative complications, nosocomial infections, readmission, and ultimately loss of capacity to live independently, largely driven by functional decline postoperatively. And if we think about it from a healthcare systems perspective, frailty is an independent predictor for increased costs in emergency general surgery of the older adult population. And building a little bit off that last point, I want to just briefly talk about this study that was done by the same group that did the E-study. And essentially what it looked at is patients over the age of 65 who underwent emergency abdominal surgery and needed assistance with less than 3 ADLs. They stratified the patients on the basis of frailty using the Rockwood Clinical Frailty Score. And the results found that, the results are on the right-hand side, and they found that patients who had a higher frailty score, maybe unsurprisingly, had a higher likelihood of readmission or death within 30 days, and ultimately that became more apparent within 6 months. And the other interesting thing with this study was that out of the 322 patients, only 11 received geriatric medicine consultation, and only 7 of those consultations were in the frail group. So possibly an opportunity there for geriatrics to become more involved in looking after this frail patient population that requires emergency surgery. So recognizing the impact of frailty on outcomes and functional decline, In 1995, in NEJM, there was a study published that looked at the introduction of the ACE model. What the ACE model was designed to do was reduce incidence of functional disability during an acute medical illness in the older adult population. There was 4 components to the ACE model. The first was a prepared environment, looking at things like carpeting and handrails to prevent falls, large clocks, calendars, looking at reorientation. The second was a patient-centered care, so daily assessment by nurses, protocolization of things like continence, nutrition, mobility, and finally communication through multidisciplinary rounds to target those things. The third was planning for discharge that really emphasized mobility and independence with an early emphasis. And the final one was a medical care review looking at daily review of medicines, planned procedures, minimizing adverse effects. In the original NEJM trial in 1995, they found that by randomizing patients into ACE models as opposed to general care, these patients were more likely to perform basic activities of daily living and ultimately have a lower proportion of patients who were discharged to long-term care as opposed to their home environment. The success of the ACE model here and other publications that successively showed its impact led to the proliferation of ACE units kind of throughout the US and here in Canada as well. And in 2012, there was a systematic review and meta-analysis published in the Journal of American Geriatric Society, which looked at acute geriatric unit care characterized by 1 or more ACE components. They've looked at approximately 13 studies, about 7,000 patients, and found quite convincing evidence that ACE components or ACE models were associated with fewer falls, a relative risk of 0.51, lesser delirium, lesser functional decline, and ultimately fewer discharges to a nursing home and more discharges to home. And again, if we think about it from a healthcare systems perspective, it's not surprising that if you have lesser in-hospital complications, improved functional mobility at discharge, it leads to lower cost per patient and reduced 30-day admission. Now, this data is from the US, so maybe the actual dollar values are not as significant, but it's the overall trend, which is quite encouraging. So what about ACE philosophies in surgical patients? That literature, I would say, is still developing and maybe not as apparent as it is in the internal medicine or the medicine wards. But there was a study published in BMC Anesthesiology, which looked at questions similar to this. Essentially, they looked at geriatric care models with the objective of determining a decrease in adverse outcomes versus standard care in the geriatric surgical patients. They looked at 11 studies, 4 of which were RCTs and 7 were non-RCTs, and about 2,600 patients in total. I want to highlight that this study was not really truly ACE patients in that they were looking at patients undergoing elective non-cardiac high-risk surgery. The ACE philosophies itself were more so developed for emergency hospital admissions. And the other difference was that the patients in the geriatric care models must have had a CGA, which again is not necessarily a part of the ACE model itself. However, looking at the outcomes, what they found was a signal towards a reduction in delirium. And so you may look at this here and say, well, the odds ratio crosses 1. This is not statistically significant, which is true. But partly the reason for that is that there is a lot of heterogeneity in the data. And if you look at the study by McDonald's et al., you'll see that it almost implies that being in the geriatric unit care model leads to a higher rate of delirium. And if you read the study, their rationale for that is that because these patients were being assessed by geriatricians in the treatment group, they were more likely to diagnose delirium, and it was just being missed in the control group. So if you remove that study, you get quite a significant result of an odds ratio of 0.44. And if you look at just the RCTs, which I believe is 3 out of these 6 studies are the RCTs, the delirium proportion was 8% in the treatment group versus 16%, which is statistically significant. So there was a signal towards reduction in delirium. Interestingly, when they looked at length of hospital stay, they couldn't draw any meaningful conclusion. It was non-significant. And I find that interesting because, length of hospital stay is very much a late outcome, meaning there's a lot of earlier outcomes such as delirium, urinary tract infection, improper medications, which can be targeted. And the hope would be if you target them, eventually you get to more of the late stream outcomes. But in this study, they did not find any change in length of hospital stay. So with that sort of background in mind, I want to start talking about the journal article I'd like to discuss, which is the EASE model. This was essentially a prospective before and after study with a concurrent control group, and we'll talk about in the next slide what that means. And it was designed to assess clinical outcomes after adoption of an elder-friendly approach to surgical environment in an emergency surgical setting. And I want to highlight the importance of that. This is truly looking at patients who just ended up in the hospital requiring emergency surgery, as opposed to elective. So what is a before and after study? I think Alana spoke a bit about it, but essentially it's a design, kind of like the name implies, evaluating the effects of a deliberate intervention by comparing outcomes of study participants prior to and after an intervention has been applied. And so if we look at this graphic right here, it actually does a really good job describing sort of what they did in the EASE study. And so over here, we have an experimental group and a control group. The experimental group in the EASE study was the University of Alberta Hospital, which is in Edmonton, and the control group was Foothills Medical Center, which is in Calgary. These patients, the emergency admissions of older patients requiring surgery were followed for a period of time in T1. In T2, there was the intervention that was applied at the University of Alberta Hospital, which was the EASE program intervention. There was no intervention applied at Foothills Medical Center, which served as the control. And then at T3, these patients were followed for a successive period of time. And the hope would be in that experimental group, you would see some outcomes because of the EASE program. The benefit of having a control group, and I think Dr. Nagley spoke briefly about this, is that, for example, if there was a rapid advancement in the way laparoscopic appendectomy is done, such that patients spent less time in the OR and were requiring less anesthetic drug, then if you had just the experimental group, you would think in T3, oh, my outcome is the reason why these patients are getting less delirium and are more functionally capable. But you'd be missing a very important confounder. And so those time confounders can be accounted for by having a separate control group. So in the EASE study, in terms of the inclusion criteria, they included all patients over the age of 65, patients with an index admission to the ACS service, and these were post-operative from acute abdominal surgery. So these did not include patients who were admitted and awaiting surgery, but were rather, the program started in the post-operative phase. The exclusion criteria included various things. The one that I will highlight is that they excluded patients who got conservative management for obvious reasons, but I want to highlight that because there are a lot of patients who, by virtue of their age, comorbidity, frailty, do get conservative management, and it was not the purpose of the EASE study to answer questions about that patient population. So this is a graphic that I created, which I'm very proud of. And what this does is it highlights the EASE model. So there was 5 components to the EASE model. The first was capacity realignment. And the idea was that the patients would be co-located to one unit whenever possible. And the benefit of that was it would be easier to implement the rest of the EASE model, but also it would raise cultural awareness and education regarding how to manage an older patient population getting surgical care. The second was interdisciplinary care delivery. And that's similar to my understanding here in the surgical wards in Toronto, but the difference was that the daily ward rounds would include a geriatric specialist. So that would either be a geriatrician or a geriatric specialist nurse. It didn't necessarily mean that all patients in the EASE model got CGAs. It just meant there was somebody there to answer questions about, medications, Foley removal, etc. The third was a pretty innovative reconditioning program, which began kind of immediately post-operatively at the bedside of the patient. We'll review it on the next slide, but it was different from the regular standard physiotherapy that we're used to in the hospital setting. The fourth was implementation of evidence-based practice. So these were things like the good geriatric principles, which we're used to. So medication review, reconciliation, prevention of postoperative complications such as VTE prophylaxis, removing Foley catheter, and education of the healthcare team as well as patients and families. And finally, the last one was similar to the ACE model from the NEJM study in 1995, transition optimization that really emphasized maximizing functional recovery and return to baseline health status. And so these were the 5 principles of the EASE model. So what was the reconditioning program? Well, it was something called the BFIT program, and it stratified patients on the basis of their clinical frailty. And if you were very fit versus if you're mild or moderately frail, you were given different exercises to do 10 times, 3 times daily. And so for the more frail group, it was more bed-based programs such as quad extensions or tricep extensions, whereas for the more fit group, it was standing-based programs such as sit to stand. And so the outcomes they looked at were a proportion of patients who experienced a post-operative major in-hospital complication or death. And we'll talk about kind of the outcomes in a bit. And the secondary outcomes were mortality or readmission at the 30 or 6-month mark, patients who had minor in-hospital complications, length of hospital stay, and requirement for alternative level of care. So let's review the results of the study. So the first figure just highlights sort of the breakdown of the patients. You'll see that the vast majority of patients that were excluded as a result of age. But there were a sizable proportion of patients who did receive conservative management that were not included. There were some other exclusions as well, such as multi-system trauma or palliative surgery. Eventually, the number of patients included were at least 140 in each of the time intervals at the control and the intervention site. So the first figure kind of highlights the distribution of the demographics at the control site versus the intervention site. There's a couple of differences I wanted to highlight here. The first is that at the control site, patients, although it wasn't statistically significant, were more likely to be vulnerable when classified on the basis of frailty. So it was more, here 61% compared to 45% at the control site. And so you can imagine that that may affect some of the outcomes that you're hoping to measure if you have a more frail population. The second is, and it's not really described why, but at the control site, patients spent a significantly less time in the OR. And so does that reflect kind of the procedures or the medications that they're getting? It's not really clear, but it's something to keep in mind. And the final thing is that at the intervention site, there was a statistically significant difference in the type of surgeries that were being done in the pre-ease phase versus the post-ease phase. And I think that's important because, I haven't reviewed all the surgery literature, but you can imagine that the amount of functional decline or the post-operative course having received closed appendectomy is quite different from having received colon surgery. One is a more invasive type of surgery. And so how that affected outcomes is something to think about when we review the outcomes. By and large, though, at both the sites, patients were quite similar in demographics. The next table highlights sort of the outcomes at the control site versus the intervention site, pre and post the EASE model. So the first thing is at the control site, we really shouldn't expect any change unless there is some sort of confounder due to time. We do see a couple of changes, which again are not really described, but at the control side, there's a significantly higher proportion of patients that were waiting for discharge, about a 20% increase in the post-ease phase versus the pre-ease phase. There's also a significantly higher proportion of patients who received a geriatric consult, and I think that probably goes hand in hand with the amount of patients that are waiting for discharge. And so again, that may skew our data, and it's something to think about. The second aspect is they did highlight a few of the adherence measures. So in the post-ease phase, there was about 52% of patients who were able to go to the EASE unit and about 52% who used a standardized EASE order set. It's not really described what that order set entails, but probably things like, VTE prophylaxis, removal of Foley, etc. And a 61% of patients approximately who participated in the BFIT reconditioning program. The next thing are the outcomes. And so what we see at the intervention site, the first thing I want to highlight is that there was a significant rise in the number of patients who received geriatric consultation, about 69 more geriatric consults in the post-ease phase. And so if you think about it from a feasibility perspective, how possible is it to do 69 more consults? In terms of outcomes, there was a significant decline in time to mobilization, significant decline in the percentage of patients who had urinary catheter, and about a day increase in duration of urinary catheter use. And finally, a significant decline in the percentage of patients who are on TPN. And quite unsurprisingly, much like previous literature, there was a significant decline in the percentage of patients who had delirium as well, which did not happen at the control site. And finally, a significant decline in the number of patients waiting for discharge. The next table talked about their primary and secondary outcomes, and I've broken it in terms of one outcome at a time because I wanted to elaborate further. The first thing was major complications or death. So they described major in-hospital complications as any one of these from A to E. So this included ICU admissions, vascular complications, serious infections, protracted delirium over 48 hours, and something called a Kelvin-Dindo grade 3 or 4. What the Kelvin-Dindo grade is a way of stratifying postoperative complications on the basis of severity. Grade 1 and 2 are considered more minor, and grade 3 or 4 are considered more serious. So what they found here is that there was a significant, a 20% almost reduction at the intervention site following the implementation of the EASE programs. Unfortunately, they don't really stratify what the reduction in major complication was. Was it ICU admission versus pneumonia? Well, we know there was about a 20% reduction, which is statistically significant. The other thing I want to highlight your attention to is something called a DID p-value. What this is a difference in difference p-values. So they looked at the difference in the control group and the difference in the intervention site, and they compared that to see if there was statistical significance. Statistical significance was less than 0.05, so this was 0.06, so it didn't meet the threshold. But I think overall there is quite a strong signal towards a reduction in major in-hospital complications with the EASE model. The second outcome that they described is something called a comprehensive complication index. What that is a validated continuous scale that summarizes all postoperative complications weighted by severity, 100 being patient death, so the most severe, and 0 being no complications. What they found was a statistically significant decline in the CCI at the intervention site, which was also statistically significant across the two sites as well, so about a 12.2 point decline. The same pattern was replicated in any complications as well as minor complications, about a 20% decrease. Minor complications were a Kelvin-Dindo grade of 1 to 2. And when it came to length of hospital stay, essentially what they found was that at least at the intervention site, there was a statistically significant decline in the length of hospital stay by about 3 days, and a statistically significant decline in percentage of patients who are being discharged to alternative level of care, and resultantly more patients were able to go home following the EASE intervention at the intervention site. This wasn't statistically different between the two sites, and I think partly driven by kind of this wide range of variation in the IQR, making it difficult to derive statistically significant conclusions. Finally, in terms of death or readmission at the 30-day or the 6-month mark, there was no statistically significant difference, both at the intervention site as well as across the two sites. And I think that gets back to what I was saying about death or readmission at the 30 or 6-month mark being really a virtue of many upstream outcomes, and this being a late stream outcome, which may not necessarily be affected, but if we affect enough of the upstream outcomes, we can hopefully lead to changes in the more downstream outcomes as well. So in terms of the critical appraisal of this study, the strengths of this study were that they really were one of the most comprehensive studies that have looked at the older adult emergency surgical patient population. This is a very diverse patient population. It's difficult to draw meaningful statistically significant conclusions, and the EASE study was able to do that. They had a very robust model applying various, if not all, elements of ACE philosophy. And they did incorporate a concurrent control group, which allows us to be more confident in the results derived from this study. In terms of the weaknesses, important to recognize there are some limitations inherent to before and after study models, particularly when compared to RCTs and how they relate to confounders. In the RCT, essentially you're just randomizing only the intervention. And so you can better account for the confounders. That wasn't necessarily the case with the before and after study model. There was also no clear justification given for why the control site was chosen. And there wasn't any description of if there was any variation in clinical practice. We can assume that both of these sites are in Alberta, and so they would be quite similar in clinical practice. But for example, I don't know if at the control site they had interdisciplinary care rounds. It just wasn't described. We should recognize that this was a selected patient population, excluded things like multi-system trauma, conservative management. And finally, if we look at it from a QI lens, and maybe it's a little bit unfair since this wasn't really a QI study, but if we look at it from a QI lens, there wasn't really a lack of measurement of performance measures capturing adherence or fidelity. And that is so important because if I want to be confident that the outcomes that I'm seeing are a direct reflection of the EAST model, I want to see performance measures such as, what kind of medications were patients on before and after, how long were the interdisciplinary rounds, what percentage of time was geriatric included in the interdisciplinary round, those type of measures to really get a good sense that the outcomes really do indeed affect the EASE interventions as opposed to other variables. In terms of the critical appraisal, I use the critical appraisal for RCTs. We can't apply it here, but this is a before and after study. And so was the assignment of patients randomized? The answer is no, by virtue of their clinical design. Were the groups similar at the start of the trial apart from the experimental therapy? So I said yes, there were some minor differences in terms of vulnerability as well as length of stay, length of time in the OR. But I think by and large, for the most part, the groups were quite similar. Aside from the allocated treatment, were the groups treated equally? And this is where I'm not really certain, without knowing more about how surgery is practiced at Foothills Medical Center. I can't really comment on where there are differences at T1 in the experimental site versus the control site. And so it's unclear. Were all patients analyzed in the groups to which they were randomized? Yes, this was an intention to treat principle. And were measures objective, or were the patients and clinicians kept blind to which treatment was being received? And you necessarily cannot do that with the study design that they had. What was the magnitude of treatment effect? And so we did see statistically significant conclusions across various measures of complications. And are the results relevant to our patient population? So I said yes, in the sense that this was a Canadian study of older adults living in metropolitan cities. And so in Toronto, we have more diversity. There may be a larger patient population, but I think by and large, the patient population was similar. And I'm hoping in the Q&A period, we can talk a little bit more about the next point, which is the treatment feasible? And I'm not really sure, without knowing more about kind of cost, how long the rounds were, how feasible is it to have geriatrics do 69 more consults? It's not really clear if the treatment would be feasible. And will the potential benefits of treatment outweigh the potential harms? And I think no question, yes, these are good geriatric practices, which we see lead to quite beneficial outcomes. So my final conclusions are adoption of the elder-friendly initiative applied to older adults resulted in clinically significant reduction in complications, including delirium, earlier mobilization, and return to home. And there's definitely opens the door to more research in terms of the feasibility, cost, and ultimately sustainability of such a model. So these are my references, and we'll move to the Q&A period.
Thank you very much, Ramiz. Another very nice presentation. I just want to point out that the senior author on the paper is Jana Holroyd-Leduc, a graduate of the University of Toronto. And Adrian Wag is another geriatrician that's a co-author on the paper as well. So open it up to questions and discussion. Gary, are you moving towards your microphone? I see some flickering there.
Yeah, Ramiz, very nice job with the presentation. So congratulations. Maybe I'll take a slightly different tack than you in terms of dispelling concerns about some of the baseline differences between the control and intervention, and particularly, or in addition, the point that you made about differences in the type of surgery done in the intervention hospital, and for example, how that may have affected the result related to length of stay, as an example. Maybe with closed surgery, the recovery period is shorter, and that contributed. So, I think those are things maybe you want to comment a bit further about. They sort of highlight the challenges, I think, of doing before, after type of studies, or quasi-experimental as opposed to randomized trials. I agree with Shabir, they're often very difficult to do RCTs in models of care, but it does pose challenges for us. We sort of have to interpret, do we think that the benefits demonstrated despite the warts that we've identified are sufficient to convince us that we'd be prepared to scale it at this point versus requiring further study?
Yeah, I think it's, so the one aspect is recognizing kind of some of those different, but I think the other aspect is just, it would have been nice to see more sort of performance measures, as well as maybe cost analysis, because I think all of that kind of goes into deciding, how feasible that would be in sort of the University of Toronto teaching hospital setting. Yeah.
Just to follow up on that, Gary, so do you think that it would have been more valuable to maybe take a QI approach to looking at whether narrowing the gap between practice and what the evidence shows in terms of best practices for some of these common geriatric conditions might be a different way of looking at some of this evidence?
Well, I'm going to defer a bit to some of our colleagues that are participating, like Richard and Samir and others who have much greater QI knowledge than me. The less robust the methodologic design, the more important collecting a variety of measures that help us understand or at least make a judgment about the results. So a QI approach, I think, would have been helpful because, again, it would provide us with some additional data that would perhaps allow us to, like I said before, you sort of have to recognize the weaknesses of study design, but then make a judgment. Do the information that you're provided give you confidence that the results are valid, and that you might consider adopting the model. So, the short answer is yes. I think additional data and a QI framework would strengthen this type of work.
And Richard, you want to comment?
Yeah, I mean, I'm basically going to echo what Gary said, but this study was, for what it is, quite meticulously done. They obviously went to the trouble of observing and trying to find a matching site with, in spite of what Ramiz mentioned, that, we don't know too much about how similar or dissimilar the two sites are from what at least is presented here. But, if we were to kind of look at this from a critical appraisal of like a quality improvement, like a rollout, the things that might have helped, because they've essentially, by having a control site, at least adjusted for the fact that there could be secular trends, change in practice, throughout healthcare that might have just been accountable for the changes identified. Yet in their case, they did show the ease unit outperformed versus a comparator. But what we don't necessarily know is like, was there actually like adherence or fidelity to the ease intervention? Was it just that happened that they have the friendly neighborhood geriatrician around? Was that like the thing that actually made the difference? Was it the BFIT program, et cetera? And this is where, if you have a family of measures, including both process and outcome measures, you can hopefully better correlate the interventions that you've made to show that you've actually kind of done what you set out to. But certainly, by the fact alone that they were able to move outcomes, I think that this was an impressive result.
Thanks, Richard. Murray?
Yes, Ramiz, I want to congratulate you on a fantastic presentation. Thanks. And from the QI perspective, I just recently did a course on qualitative metrics in quality improvement. So one thing that I'm thinking is, qualitative information can help explain some of the difference, and we don't have any of that. And one thing that I think about this kind of study is the role of family. We don't have a metric of how often family was involved in the care of the patient. And I'm just thinking from personal experience, when my mother was in critical care and had a surgical emergency, how our role was key in really helping her having exceptional outcomes. But we see that on the medicine ward similarly, when families are very involved around the older person, how that impacts the recovery. And this is a metric that was not captured.
Yeah.
Or am I missing on that?
No. So I mean, one of the things they tried to do was increase education around kind of healthcare workers, families, the patient themselves, but it wasn't really elaborated on what that exactly entailed, and how successful they were, kind of building off Dr. Norman's point about how adherent they were and how it was practiced in the clinical setting. So I'm not sure. Yeah.
Any other questions or comments?
It's the non-geriatrician here, Carol Cohen. I'm just concerned about the number of people who went on to have a geriatric consult. So it's just very time consuming, expensive, and not really feasible. So I was concerned as to why the rounds with the specialists weren't enough.
Yeah, I think that's a fair point. I wonder if there are some other factors to think about, things like, if you're on the rounds and you're making, recommendations on a patient, like strictly speaking, like from a billing perspective, could you also then bill for that patient if you go on to do the consult? That might be something to think about. Otherwise, it didn't seem to me like in the pre and post-E's group, there was necessarily an increased frail population. So I'm not entirely sure why there were so many more consultations that were being done. It isn't described, but you're right. My first thought looking at that was, how would we fit that into the day-to-day work of surgical consult service or a consult service like geriatrics?
Marisa?
I just had a comment. Quite a while ago, I reviewed the ACE literature, and there were meta-analyses to try to find out which component of the ACE interventions were the most significant. And for example, early discharge planning was not the most significant, nor was the so-called prepared environment. And but of course, it took about 14 such randomized controlled trials of ACE models in order to try and see which of the elements was the most impactful, let's say, in bringing about a positive outcome. And this may be the case for this research in the surgical world, that you just need more information to find out whether it was the FIT program that made the difference, the geriatric consultation, or the daily rounds from the nurse, or just the educational package that was put together for the families or somebody else. Because it's like almost like a black box effect here, right? We just don't know, but we know that this black box gives a better outcome.
Yeah.
I just want to follow up on that, is that the other surgical approaches that have been endorsed by a lot of organizations is the ERAS, the Enhanced Recovery After Surgery. And we often say what's good for older adults is also good for other patients. And they have a significant overlap with many of the care processes that are highlighted in the ACE approach as well. So early mobilization, having bowel movements, the usual sorts of things that are important in surgical recovery for older adults is also beneficial for the younger population as well. And there's a lot of uptake on the ARAS approach in the surgical environment.
I just one comment to extend on what Marissa had said. It's just if we were to redo this study with like a quality improvement kind of approach, you might do a like phased rollout where you would introduce different parts of the bundle like over a period of time, with the idea that then you could track your metrics and ideally better understand which parts are the kind of impactful parts on your outcome measure, rather than dumping everything at once and then doing a retrospective look after a few months to see if things are better or not. That's and especially if you have an evidence base where you have a kind of a good idea that something is going to work, it may help you to kind of sort out where to best apply your resources. Now, this is an appropriate design for kind of a pilot study to test out a new bundle, but it's just, it would be a different way of potentially approaching this same question.
Yeah, that's a good point, Richard. And I, so just thinking about how long sometimes it takes for change to become embedded into practice when we're talking about changes that are not, that are potentially more complex. So that sort of staggered rollout can be challenging in terms of when the effect is actually manifest. We only have 1 minute left, and I do just want to